Joy, muted, Joy, muted, Joy.
Gangadharan sir, good evening. Andrew sir.
Andrew sir, thank you. Good evening.
Welcome.
Joy, unmuted the sir, Joy.
Dr. Sharmila, Dr. Pavan,
Yes, sir.
flag salutation.
Flag salutation, parate.
Yes, Pavan.
Flag salutation. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, Jai IMA.
Thank you, Pavan. I invite Dr. Joy Manjila for the presidential address. Over to you, sir.
Thank you, Dr. Sharmila. Respected Chief Guest, Dr. V P Gangadharan, President AMPOK and Head of the Department, Medical and Pediatric Oncology, Lakeshore Hospital, Kochi. Our Secretary, Dr. Pavan Madhusudan, Treasurer, Dr. Joseph George, IMA CGP Thrissur Chairperson, Dr. Leelama Abraham, Convener, Dr. Sharmila P A, AMPOK Secretary, Dr. Boben Thomas. AMPOK means Association of Medical and Pediatric Oncologists of Kerala. Moderator, Dr. Anil Thazhath. Our today's faculty is Dr. Meera Mohan, Dr. Mithun, Chacko, John, and my dear colleagues and senior IMA leaders of state and other IMA branches. A warm good evening, and I welcome you all to this CME on World Cancer Day 2021 with the slogan, I am, I will. As you all know, World Cancer Day is celebrated on 4th February.
Automatically
Last two years, we conducted cancer detection camp with the help of RCC Palakkad and awareness classes for the public. But because of the COVID-19 pandemic, we are forced to restrict to CME with the expectation we can conduct camps as we did in the past years with the advent of COVID-19 vaccine. Few words about our relay hunger strike in protest against the myxopathy. On our turn of hunger strike is on 13th Saturday, and we will be conducting at Tekinkad of Tekinkad Maidan from 8 AM to 6 PM. We need volunteers for the same, and those who are willing, please do contact me or Dr. Pavan. Wishing you all an excellent journey. I conclude. Thank you all. Over to you, Dr. Sharmila.
Thank you, sir. And next is actually, we are blessed today to have as our chief guest, Dr. V P Gangadharan. I know that introducing sir will be superfluous, but as per protocol, I need to do it. So here goes. Sir started as a career, his career as a tutor in radiotherapy and medical oncology at Medical College Thrissur. Later, Sir joined RCC Trivandrum in 1989 as assistant professor and head of medical oncology. Sir established the medical oncology department in RCC, the first of its kind in Kerala. Sir underwent bone marrow transplantation training program in USA and UK with NCI and WHO fellowships. Sir is involved as a teacher in graduate and postgraduate training programs and as examiner of DM medical oncology at various universities. And right now, sir is the president of the Association of the Medical and Pediatric Oncology Kerala, and sir is the head of department of the Department of Medical and Pediatric Oncology at Lakeshore, Kochi. Over to you, sir. I would welcome sir for the inauguration of today's CME. Over to you, sir.
Thank you. Am I audible?
Yes, sir.
Thank you.
Audible.
Yeah, good evening to all of you. I don't want to name each one because a lot of familiar faces, including some of the remembrances of my college days with Dr. Srivilasan sitting in front of me, because I think he has become, I think, less bald and more young now after seeing him now. And a lot of them, I think Dr. Mithun, Anil, and a lot of them, I think of my friends are in the screen now. First of all, thank you for inviting me, for inviting your program, or inaugurating your program. I think it's a good gesture because when I started my career 30 years back, I don't think that any IMA would have dared to conduct a meeting like this, because there was no oncology at that time when we started. And it was something like a, left out specialty. But now I am sure that all of us are behind this, including, I think I can see Dr. Meera also here. I heard that she's from IMA Thrissur. That's good, because I think a lot of youngsters are pursuing the career in oncology now. Coming to the topic, I think 2019 to 2021, the 3 years, the World Cancer Day, I think slogan is I am and I will. February 4th. This is more relevant in the last 1 year when we were all behind the COVID. I'm happy to see that or to note that all the oncologists should be called as heroes, along with the cancer patient and their family, because we all fought against two major diseases, that is cancer and COVID. I think all of us are just like the frontline health workers. We all were, forgetting forgetting our problems and our risks, and we are all involved in the treatment of cancer in the last 1 year without breaking any of the chemotherapy schedules, without trying to not to get the treatment interrupted. That's why I said all the oncologists should be called as heroes at this juncture. Topic is again a very relevant topic which you have taken out today. Of course, am I audible now, or is it a problem?
No, you are audible. You are audible.
Audible, sir.
I think the topic taken today is also something very, relevant and very up to date, like a myeloma, which I would have treated with only 2 drugs when I started my career, like melphalan and steroids. To what more now, or what next now? I think that is where we are now. All the advances happening in that field. Of course, Dr. Mithun, Dr. Meera is talking, and Dr. Mithun is, I think, going to glimpses of how the oncology, especially medical oncology, has changed over the last, 25, 30 years. Good topics. I think this becomes more relevant because as you know, I am and I will. It's not for the public alone. We as doctors should also repeat the same slogan, I am and I will, whichever branch of medicine you are, including the general practitioners. Why I'm telling you is because I think everyone has to play a big role in that slogan, like starting with prevention, early detection, and knowing and doing the treatment. So
mortality has been reported as high as 30%.
I think we all should enter into this society fully knowing the slogan, because we all have to have our duty to be done. Like prevention, yes, you have to teach the public, and especially the college and school children. I think they should know about the prevention and detection camps and detection. I think everything goes. And even if you don't treat, I think you should be very much aware of what are the updates or what is the present status of treatment of each and every cancer. So I think a very relevant topic for a doctor also with the same slogan, I am and I will. I think so. As of now, I see today that it's going to be a very good session for you, maybe lasting for about 1 year, 1 hour plus. And I'm sure that all of you will go back having enjoyed a good evening. Enjoyment means enjoyment in terms of a good academics. And with all your permission, I am declaring this event as open. Thank you. And again, with your permission, I may be permitted to leave because I had to join for another meeting at 8 o'clock. Thank you. Thank you once again.
Thank you, sir.
Thank you, sir. Thank you, sir. Next, I would like to welcome Dr. Boben Thomas, Secretary AMPOK, for the welcome address.
Good evening. Good evening, all. First of all, I would like to thank the office bearers of IMA Thrissur for this opportunity. My good friend, Dr. Mithun Chacko, will be delivering this talk. We have been organizing multiple meetings across in various IMAs, and this is the first time an AMPOK association office bearer has been asked to deliver this inaugural address. And this itself, I feel like it's a great honor for the association. And here I am representing my association, that is AMPOK, the Association of Medical and Pediatric Oncologists of Kerala. This association was formed 3 years back, and we currently have 72 members. Most of them are medical oncologists with a couple of pediatric oncologists as well. So as V P Gangadharan sir has mentioned, sir was the first person to join the specialty of medical oncology in Kerala. And that time he was a single fighter, single person. And right now we are equipped, the specialty is equipped with about 72 trained members who are practicing right from Trivandrum up to Kasaragod. So, and this, we have been organizing multiple meetings for general public as well as to the non-oncology doctors on the various developments that has happened in the field of oncology. We all know that several misconceptions exist in the field of oncology, even among doctors. Most of the doctors outside oncology specialty are not aware of the latest developments that is happening in the field of oncology. Medical oncology per se has evolved in the last couple of decades. And from as Gangadharan sir was mentioning about the drug multiple myeloma, when he started his career, he just had about 2 drugs, but now we have a handful of drugs to treat this disease. Same thing with multiple other diseases also. So this is an opportunity from on our behalf for educating the general public as well as the general doctors on the latest development that has happened in the field of oncology. So without wasting much time, I would like to thank the office bearers once again for giving us this opportunity. And together we will say, I will, and I am, not I am, we all, and we will fight against this disease. So, and over to you, sir. Thank you.
Thank you, Dr. Boben. Next will be felicitation by Dr. Leelama Abraham, Chairperson, IMA CGP. Leelama, madam. Leelama, madam.
Yeah, and I will move on to next.
Okay, sir. Today's moderator, I would like to introduce Dr. Anil Thazhath as today's moderator. Dr. Anil Thazhath is MD, DM and Head of Department of the Medical Oncology and Haematology of Amara Institute of Medical Sciences, Thrissur. Over to you, Dr. Anil Thazhath, for moderating today's program. Thank you. Sir.
I'll muted. I'll unmute you, Dr. Please unmute.
Okay.
Hello. Am I audible?
Yes, sir. Yes, sir.
Yes, yes. You are audible.
There was a technical problem. That is why I was a little late. I'm sorry. Dr. Joy, shall I?
Yeah.
Yeah. Okay.
You can introduce
Dr. Sharmila for your introduction, and I thank Dr. Joy and IMA officials for inviting me to moderate this scientific session. And I congratulate the IMA Thrissur for conducting this meeting in connection with the World Cancer Day. And I think the topics you have selected also is very apt and relevant, because basically if you see the evolution of cancer treatment as such, the main stress was from the crude chemotherapeutic treatment, targeted treatment, or less, treatment with less side effects definitely gives a better survival as well as the quality of life has emerged. So now this we have two topics. One is myeloma, the other one is on the evolution of cancer chemotherapeutics, medical oncologist perspective. And myeloma is a disease which is the best example of the concept which I have told. Now, when I actually started my practice in 1990s, myeloma had only very limited options of treatment. Tablet, melphalan, then some the better or relatively younger patients, we could have given the combination treatment like VAD with side effects and the survival on an average of 3 to 4 years. And then came the marrow transplant, but the patients who are eligible were very few. But there was a paradigm shift in the concept of treatment. What you call we have started getting drugs, what you call the targeted drugs, with very low side effects and definitely the improved the survival rate. The drugs like thalidomide, lenalidomide, and then ortizomib, carfilzomib, pomalidomide, and now we have monoclonal antibodies like daratumumab, all came, and thus basically the survival has improved drastically, even without the transplant benefit. Like from 3 to 4 years to actually it is almost doubled, and more that has happened without much side effects. The drugs which we are using now have very low side effects. So quality of life has definitely improved. So that is the main idea, to increase the survival with definite improvement in the quality of life. So myeloma is a prototype of this concept. And to talk on this subject, we have an international faculty with us, Dr. Meera Mohan. She has graduated from Government Medical College Thrissur in 2008. After that, she went to USA and took internal medicine residency in Wayne State University, Detroit, followed by 3 years of fellowship in hemato-oncology in the University of Arkansas. And she worked there in prestigious Myeloma Institute in the Arkansas campus for some time, and then now moved to marrow transplant service at Medical College, Wisconsin, USA. She has published several articles in high impact journals like Leukemia, Blood Cancer, British Journal of Haematology, American Journal of Haematology, etc. And her work in minimal residual disease and multiple myeloma has been presented in the ASCO 2020 and has been awarded the one of the top abstracts and awarded ASCO 2020 Conqueror Cancer Merit Award. With these words, I invite Dr. Meera to deliver her talk. I just want to tell Dr. Meera that the audience is a mixed, heterogeneous population with a very few hematologists, medical oncologists, some physicians, and mostly general practitioners and other specialties. I think you can give justice for all this population. You can take approximately 20-25 minutes, and then we'll have a discussion before the second talk. Dr. Meera, please.
Thank you, sir, for the kind words. Good evening. I would first like to thank the IMA and the organizers for this wonderful opportunity. So it's a pleasure here to present the state-of-art therapy in multiple myeloma as in the US. So multiple myeloma is a rare cancer. It only accounts for 2% of all the cancers diagnosed in the United States and 10% of all hematological cancers. Myeloma, as we know, is derived from expansion of mutated and terminally differentiated post-germinal B cells. The pathogenesis of myeloma is pretty complex. This is a simplified version here. The orange cell that we see on the slide here represents the naive B cells in the germinal center of lymph node. Upon antigenic stimulation, this cell undergoes transformation into the post-germinal center mutated B cell. It is thought that the primary genetic mutation in plasma cell neoplasm founding clone occurs at this stage. This cell further migrates to the bone marrow, where it differentiates into mutated long-lived plasma cell. And this plasma cell further accumulates de novo mutation. So indeed, this is a multi-step process, which is almost always preceded by an MGUS state. So myeloma evolves from a benign state called MGUS. Then we have what we call a smoldering state, and then active myeloma. MGUS, by definition, has a lesser tumor burden with an M protein of less than 3 grams per deciliter. The clonal plasma cells in the bone marrow is less than 10%. Smoldering myeloma, on the other hand, has a higher tumor burden. And then we all have heard of the SLIM criteria for the diagnosis of multiple myeloma. In 2014, the International Myeloma Working Group had added 3 new diagnostic criteria, namely bone marrow plasmacytosis of more than 60%, free light chain ratio of more than 100, and an MRI-defined focal lesion. Thus, in 2020, the diagnostic criteria of myeloma expands beyond the end organ damage to a disease that by definition includes patients with no end organ damage and are totally asymptomatic. Thus, it's no longer CRAB, it's what we call the SLIM CRAB criteria. More recently, there's been a lot of attempts in better risk stratifying smoldering myeloma. Smoldering myeloma is a heterogeneous group. It has a subset of patients that behave like MGUS, and it has a subset of patients that behaves pretty much like an asymptomatic CRAB negative myeloma. So in 2018, the Mayo Clinic researchers published what we now call the 20-20 criteria. So what it means is this criteria identifies patients who are at high risk for transformation from the smoldering state to full-blown multiple myeloma. 20-20 stands for a plasma bone marrow cytosis of more than 20%, serum M of more than 2 grams, and a free light chain ratio of 20. So thus, the 20-20 criteria robustly predicts the risk of progression to multiple myeloma. So where do we stand in 2020? We've had 2 randomized controlled trials that are published that treats the high-risk smoldering myeloma patients with lenalidomide therapy. However, the two pressing questions remain unanswered. Does early treatment of smoldering myeloma improve the overall survival of our patient? What does this mean to our patient in terms of quality of life? Additionally, I would like to point out that treatment of multiple myeloma is expensive. 1 year of lenalidomide therapy can cost up to more than $200,000 per year. So thus introducing these agents at an early course would result at an increased therapeutic burden at a great cost to a society. Thus, the standard as of 2020 remains close observation. Switching gears to multiple myeloma, I'll take you guys through a case study here. We have Mrs. X, who's a 62-year-old lady who presents with mid-thoracic back pain. X-ray shows multiple lytic lesions. How do we proceed from here? The clinical symptoms and signs of multiple myeloma are pretty vague, and a high level of intuition is required for the accurate and promptly diagnosis. So what are the investigations we typically order in such a patient? Serum protein electrophoresis helps detect M spike in the serum. M spike represents a large amount of monoclonal proteins that are secreted by the plasma cell clone. Serum free light chain assay helps detect the free light chains that are circulating in the blood. So clonal plasma cells produce the whole IgG protein, but it also produces extra light chain. This is important because this free light chain can result in kidney damage. It can cause what we call light chain deposition disease, and in cases, amyloidosis as well. Serum immunofixation helps us determine the subtype of M protein, and the kappa lambda ratio indicate excess of one type of clonal plasma cells due to myeloma. So our patient undergoes laboratory evaluation. She meets all the 4 CRAB criteria. Peripheral smear here shows rouleau formation. Bone marrow biopsy reveals plasma cells were a kappa restricted. Fluorescent in situ hybridization is emerged as one of the most useful and reliable methods for detecting the chromosomal abnormalities and should be performed in all patients that are newly diagnosed with multiple myeloma. So our patient undergoes FISH testing in the bone marrow and reveals hyperdiploidy in 55% of the cells. So she also has an M protein in the serum. The free kappa light chain is elevated, and immunofixation shows an immunoglobulin kappa isotype, which is the most common type of myeloma. So this slide is a pretty simplified summary of the primary genetic events in multiple myeloma. We could broadly divide the myeloma into hyperdiploid myeloma and non-hyperdiploid myeloma. Hyperdiploidy is nothing but multiple chromosomal gains, mainly of the odd chromosomes, and this accounts for the most common type of myeloma. So over the past decade, there has been a lot of interest in developing a robust risk stratification system that could easily be adapted in the clinic. We've all heard of the Salmon-Dury classification in multiple myeloma. This is largely replaced by the ISS, or the International Staging System. Now what we call the revised International Staging System that incorporates beta-2M, serum albumin, along with cytogenetics and serum LDH. So what is new in the last couple of years? So as a part of the international collaboration, the Myeloma Genome Project studied the largest data set of newly diagnosed multiple myeloma to date. So in this study that was done in the University of Arkansas and published by Dr. Walker in Leukemia in 2018, they describe what they call a double hit myeloma. It accounts for a very small population of newly diagnosed myeloma that has extremely poor outcome with a median survival of less than 2 years. So the introduction of gene expression profiling has been an important step in understanding the molecular heterogeneity of myeloma. This is the University of Arkansas 70 gene model that predicts high risk multiple myeloma. And this actually outperforms all the known traditional myeloma risk stratification tool in practice. Myeloma is not one disease. It has several molecular subgroups characterized by unique gene expression profiling patterns and clinical features. Let's switch back to our patient in question. So our patient has undergone a plain X-ray. So in 2020, absence of bone disease on skeletal survey is not adequate. For a lytic lesion to be evident on a plain X-ray, 70% of the bone should be decalcified. And we have today novel imaging techniques like PET-CT and whole body MRI that can detect this damage at an early stage. PET-CT provides valuable functional information based upon increased glucose uptake and glycolysis of cancer cell, and it depicts the metabolic abnormalities before morphological alteration. And you have what we call the diffusion-weighted MRI. So each of these novel imaging techniques have their pros and cons. PET-CT is a good test in diagnosing extramedullary disease, and MRI is a good test in diagnosing focal myeloma lesions. So focal myeloma lesions are nothing but aggregates of plasma cells that we see in the appendicular and axial skeleton. These are important because these lesions in the bone harbor high-risk mutation and can result in disease resistance and relapses. So in fact, this published study shows that the presence of more than 3 focal lesions at the time of diagnosis confer inferior progression-free and overall survival in newly diagnosed multiple myeloma. We have similar data with MRI-defined focal lesions as well. So today, in 2020, these are some of the modern imaging techniques that should be offered to our patients. Ideally, both MRI and CT, because these are complementary tests. But if this is not available, at least a low dose whole body CT should be offered to our patients. Now, switching gears to the treatment of multiple myeloma. The key elements of modern therapy includes induction therapy, autologous stem cell transplantation, consolidation, and maintenance. The idea here is induction chemotherapy helps reduce the tumor burden. Transplantation helps to induce complete responses and deeper remission. Consolidation and maintenance therapy will reduce the tumor burden that is left after autologous stem cell transplantation. So we've all heard of thalidomide, the drug that causes dreaded fetal abnormalities in babies. But in 2016, thalidomide came back as one of the first agents over a decade to be approved for the treatment of plasma cell myeloma. The idea was thalidomide inhibits angiogenesis, and angiogenesis is important in cancer. So this drug was actually first studied at the University of Arkansas, where in 1997, the first patient treated with this drug failed to respond to thalidomide, but a patient who was simultaneously treated responded. And this led to Dr. Barlogi and the colleagues at the University of Arkansas to conduct the first study of thalidomide in relapsed refractory myeloma. And this led to the New England Journal of Medicine publication and subsequent approval of this drug in 2006. Nowadays, we don't use thalidomide in the clinic anymore because of the side effects. And we have successors like lenalidomide, pomalidomide, and ibadromide. Now, switching gears to bortezomib. Bortezomib is another important backbone to myeloma treatment. The idea here is normal cells produce proteins that are degraded by the proteasome system in the body. Bortezomib blocks the proteasome degradation. Thus, the proteins accumulate in the cell, resulting in endoplasmic reticulum stress and plasma cell apoptosis. So this study done by the US SWOG group led to laid foundation for induction chemotherapy with triplet agents, bortezomib, lenalidomide, and dexamethasone. And this remains the standard of care even in 2020 for all newly diagnosed multiple myeloma patients. So here we are upon the daratumumab era. Daratumumab is one of the first monoclonal antibodies that was approved in multiple myeloma. It's a fully human IgG kappa monoclonal antibody that targets CD38. CD38 antigen is expressed in multiple myeloma cells. So today, daratumumab is approved in both relapsed as well as newly diagnosed multiple myeloma. Switching gear to the most important and the time-tested therapy in multiple myeloma, high-dose chemotherapy and autologous stem cell transplantation. So even 30 years after its introduction, transplant remains a standard of care, and it should be offered to all newly diagnosed multiple myeloma patients. Age itself is not a criteria to deny a patient of autologous stem cell transplantation. In fact, in our own practice, we transplant patients up to 75 and even 80 years old if they are otherwise fit. So we all speculate, how does a patient do post-transplantation? Here we present the long-term outcome of transplant-based approach in myeloma. The 5-year survival in patients who are transplanted is approaching 70%. And bottom line, transplant is safe, associated with very low transplant-related mortality and favorable long-term outcome. In fact, myeloma is the most common indication for autologous stem cell transplantation in the US. Switching gears to maintenance therapy. Maintenance therapy is pretty much prolonged therapy that is done after autologous stem cell transplantation to eliminate the minimal cancer cells that are left. And the idea is to reduce the risk of relapse and prolong progression-free and overall survival. The take-home message here is autologous stem cell transplantation remains the preferred therapy in patients diagnosed with multiple myeloma and should be offered to all eligible patients. Myeloma is a disease that is characterized by a relapsing course. This is one of our own patients who've had 3 relapses in 1 year. As the disease evolves, the myeloma cells can survive outside the bone marrow, and this results in what we call extramedullary disease. And this is a serious therapeutic challenge. So most myeloma patients will relapse, and treatment on relapse depends upon the patient and tumor variables. But the future looks bright with the advent of immunotherapy. So just briefly touching on the atypical presentations of plasma cells. So plasma cell dyscrasias can present as solitary bone plasmacytoma and solitary extramedullary plasmacytoma. So extramedullary plasmacytoma this is a picture of an extramedullary plasmacytoma in the stomach, eyelids, and bronchus. So in solitary plasmacytomas, usually the treatment is radiation, but we should have a close discussion about the benefits of systemic therapy, especially in the setting of extramedullary plasmacytoma and multiple bone plasmacytomas. Briefly about amyloidosis. AL amyloidosis results from deposition of misfolded beta-plated sheets of amyloid fibril in various organs. So the patients could have symptoms depending upon the organ involvements, and most of the time the symptoms can be subtle and one has to really look deep to diagnose amyloidosis. We've had patients that present with persistent orthostatic hypotension, which eventually led to a diagnosis of amyloidosis. The treatment in amyloidosis is two-pronged. Most of the treatment is directed against reducing the concentration of the precursor protein. So what's the role of transplantation in amyloidosis? Unlike myeloma, in amyloidosis, patient selection is vital because cardiac involvement can drive mortality after transplant. The transplant-related mortality in myeloma is 1%, while in amyloidosis, it could approach up to 25 to 30% unless the patients are selected adequately. So, but the good news is we are doing better with transplant in the recent times. This is data from the CIBMTR that shows that the early mortality rates have come down to from 20 to as low as 5%, and the overall survival is increasing from 55% to 77%. Light chain deposition disease is another rare presentation where you have non-amyloid immunoglobulin light chain that do not stain with Congo red and that do not exhibit the fibrillary structure. They can deposit in various organs and cause end-organ damage. This is actually a picture of one of my own patients who presented with impending spinal cord compression that was pretty much eroding into his spinal vertebrae. So this patient's underwent neurosurgical intervention, and the pathology revealed the plasmacytoma here. Interestingly, this patient did not have evidence of bone marrow involvement, and there was no evidence of plasma cells anywhere else in the body. But however, this small amount of tumor produced enough light chain that deposited in the heart of the patient, resulting in light chain deposition disease of the heart. So this is one of our own publications, which is the largest series to be reported on light chain deposition. So light chain deposition of the heart can be seen in 30% of patients, and they do confer an inferior outcome. The transplant-related mortality in these patients are also high, about 11% compared to 1% in myeloma patients. So patient selection is again vital, especially in the setting of a transplant-based approach. So what is minimal residual disease testing? Minimal residual disease, or MRD, stands for the small amount of cancer cell that remains in the body after treatment. So today, the diagnostic test that we use in our clinic only detects the tip of the iceberg. We have modern advanced testing like next generation flow cytometry, next generation sequencing that can help us detect minimal residual disease. So why is it important? This minimal residual disease clone represents the highly chemo-resistant clone that can result in disease relapse. And so eradication of minimal residual disease clone is vital to curing myeloma. So this is one of the latest among the series of meta-analysis published by Dr. Munshi and colleagues from the Dana-Farber Cancer Institute. This pretty much shows how MRD status is very important in every stage of the disease, irrespective of disease status, irrespective of treatment administered. And in 2020, the goal of myeloma treatment is to eradicate MRD clone in the bone marrow. So we are here in time for a second major paradigm shift. This picture here shows the several immunotherapeutics in the pipeline for multiple myeloma. The idea of immunotherapy is to harness the body's T cells to fight cancer. So we have the bispecific antibodies, which binds to the T cells and cancer cells and brings them together, thereby inducing a T cell mediated cancer cell death. And then we have what we call the antibody drug conjugate. So this is a monoclonal antibody, which has a potent cytotoxic agent that is attached to the monoclonal antibody using a linker. The advantage here is that the monoclonal antibody specifically binds to the cancer cells. Thus, the cytotoxic agents are delivered directly to the cancer cells, minimizing the off-target effect. In fact, we have the first antibody drug conjugate, belantamab, that was approved for relapsed myeloma in 2020. CAR T therapy, or chimeric antigen T cell therapy, is perhaps the most exciting therapeutic approach in the treatment of multiple myeloma. So normally, cancer cells have the ability to hide from T cells, but in CAR T therapy, the cells from the patient, the T cells from the patients are harnessed, they're genetically modified, and now they have the ability to recognize and kill cancer cells at the speed of light. So renal failure, again, in myeloma is a serious issue. It's seen in about 20 to 40% of all the patients. It is an emergency, and every effort should be made to identify the patients and treat them promptly with the hope of reversing the renal function. Bone disease is present in about 80 to 90% of patients, and patients with myeloma should be offered bisphosphonates, denosumab. We should be on the lookout for impending or actual long bone fractures, spinal cord instabilities, etc. This is one of our own work where we showed that patients who present with lytic lesions, a majority of them, 50% of the patients presenting with lytic lesions, tend to heal with transplantation. So why is this important? In majority of the patients who have a stable lytic lesions, surgical intervention can be avoided. Patients can be monitored closely with expected management. So this is one of the latest work that shows that, in fact, 70% of the patients heal with treatment, and female patients and high-risk patients heal faster. And alkaline phosphatase that we do routinely in the clinic can help identify patients who heal fast. Like in any cancer, myeloma patients are prone to thrombotic events. The treatment with thalidomide, lenalidomide, chemotherapy combinations also increase the risk of VTE. Infection is also a major risk in our patients. Myeloma and treatment regimens are associated with myelosuppression. They increase the risk of infection, decreases the quality of life, and can result in serious treatment interruptions. We should pay attention to keep the immunization status updated in our patients, and every patient should be offered acyclovir prophylaxis, especially when they are on proteasome and daratumumab therapy. So over the last several minutes, we discussed how the newer therapies have evolved and how the field has come a long way from a survival of 20% to 70%. But what is the price we pay to be where we are today? The treatment of multiple myeloma is expensive. 1 year of triplet therapy with lenalidomide, bortezomib, and dexamethasone could cost as high as $300,000. If you were to add daratumumab to this combination, the prices can go up to $600,000. In fact, multiple myeloma is one of those cancers associated with the prolonged inpatient hospital stay. Each day in the hospital can cost $2,500. So it's not cheap. So no talk is complete without briefly touching on the current SARS-CoV-2 pandemic. So our patients are at high risk for mortality compared to a non-cancer patient. The major predictors of mortality in our patient are consistent with those seen in general population. So we have a recent data that shows that patients on active chemotherapy may not be at high risk for COVID-19 infection. In fact, chemotherapy should not be held in these patients. So this slide here briefly touches on the National Comprehensive Cancer Network guidelines on COVID-19 vaccination. Our patients with cancer should be prioritized for vaccination, and immunization should be administered when they are available. Patients on active therapy should be immunized with the understanding that we have limited safety and efficacy data. Patients post-transplantation could be immunized at least 3 months post-transplant. This is to enhance the vaccine efficacy. Vaccination should also be offered to the caregivers and household contacts of our cancer patients. As we celebrate the advances in myeloma, we remain humble in our recognition of the many lives lost in the heroic battle with advanced myeloma. I would like to take this opportunity to thank our patients and family for their support. Thank you.
Thank you, Dr. Meera Mohan, for your lucid talk. And she has shown us how the treatment of myeloma evolved during these last 2 decades to a very good survival rate. I think we can have a few questions. I think I'll start by asking
Dr. Anil,
one question.
at the end of the program,
Joy.
we can have, at the end of the session, both sessions, we can have questions.
Okay. So, we can reserve the questions to the end of the scientific session.
I hope Dr. Meera can stay till then. You are muted. You are muted, doctor.
Yeah, I'll be here. Thank you.
Okay.
Okay.
Then it's okay. So we'll then move on to the next topic, that is the evolution of cancer therapeutics in a medical oncologist perspective. As you know, the treatment of cancer has basically 3 modalities: surgery, radiation, and systemic treatment. So the treatment of cancer actually evolved from even 3000 BC onwards with a barbaric surgery, and now there is development in each field. Like in surgery, we have organ preservation surgery and even robotic surgery. And in radiation oncology, from the crude radium cobalt, etc., to the linear accelerator, multi-leaf collimator, and CyberKnife, IMRT, IGRT, which gives more precise treatment. And now we have reached up to proton treatment. That is the latest trend in radiation oncology. Basically, every treatment, what is being done is to reduce the side effects and improve the survival. Now, I would say that medical oncology, being the youngest field, has shown or has witnessed the dramatic change in the last, at least in the last 2 decades. From chemotherapeutic agents where there is a destruction of normal tissue, also with large number of side effects like marrow problems and leukopenia, infection, etc., and gastrointestinal problems, etc. From that area to the targeted therapy, where we target only the tumor tissue, and the main aim is to reduce the side effects and definitely increase the survival. We have monoclonal antibodies, we have small molecules like TKIs, and now we have reached up to the the personalized treatment in oncology. To talk on this subject, we have Dr. Mithun Chacko, who also graduated from Thrissur Medical College, Government Medical College, and then he took MD in General Medicine from Gandhi Medical College, Bhopal, and the DNB in Medical Oncology from Rajiv Gandhi Cancer Institute, Delhi. He has a ECMO degree also in medical oncology, and presently he is working as the Chief Consultant, Department of Medical Oncology, Jubilee Mission Hospital. Previously, he was working at Amala and the Lakeshore Hospital. He has received several awards. The notable ones are winner of Lawrence Young Scholar Award in Medical Oncology at national level, and was awarded the Best Resident at Rajiv Gandhi Institute and Research Center, Delhi. Over to Mithun Chacko for his talk.
Yeah, thanks for the nice introduction, sir. I think Dr. Meera has to stop sharing the screen so that I can share. Yeah. Yeah. Yeah, am I audible?
Yeah, audible.
Are the slides clear?
Yes.
Yeah. Yeah, first of all, let me thank the IMA Thrissur branch for giving me this opportunity to speak in front of the august audience. So why the CMA actually? The CMA is done to celebrate the World Cancer Awareness Day. We all know it's on February 4th. So why this World Cancer Awareness? So this is to make people and the general population aware about the various myths and misconceptions about cancer. So there are a lot of misconceptions about cancer actually. So the greatest misconception is that cancer means death sentence. So this has to change. Another misconception that is that the cancer treatment, that is the cancer therapeutics or the chemotherapy or the systemic agent that are using, have too much side effects that some persons prefer not to get treatment done and rather die of chemotherapy. So this has to change. So not all patients require chemotherapy also. As everyone has mentioned, I'll be briefly discussing about the evolution of chemotherapy, the targeted therapy, and the newest kid in the block, the immunotherapy. So before going to all this, just I'll give a simple example why it's so important to know the cancer therapeutics or the treatment that development that has happened in cancer. I'll give a simple example of a patient of mine. She's a doctor by profession. She's a modern medicine doctor, has been working all her years. She must have referred many patients to the surgeons, doubting breast cancer with breast lump, doubting as breast cancer, but she herself had a breast lump. And she didn't go to any doctor fearing or knowing that it may be a breast cancer. So that is the fear factor about cancer in general population, not only in general population, in well-trained doctors who have practice of more than 25 years. She ultimately came to me because her husband brought her because she had lymphedema. She had a left breast lump and she had a huge left upper limb edema, lymphedema because of the left axillary lymph node. And her husband brought her to me. And when investigating, she had a left breast with lung metastasis. That means it is beyond cure now. It's a stage 4 disease. So if she had been diagnosed earlier, we could have easily cured her. So this fear factor, even for well-educated, well-trained, even the modern medicine doctors are fearing about cancer. This fear should be out of our mind. But luckily for her, she was estrogen receptor positive, and we could start her on aromatase inhibitor, letrozole, a simple tablet, very cheap tablet. But together with that, we added on cell cycle inhibitor, the newer drug, CDK4/6 inhibitor. These two are tablets actually. And there's a tremendous response. And touch wood, after 2 years, the latest PET scan done 1 month back is almost showing a complete response. So this is a glimpse of the development that's happening in the cancer treatment. So first of all, before starting the topic, I just have to know that fear factor should be out of our mind in cancer treatment. The taboo of cancer should be out before going into this topic. So I'll be discussing about the evolution of cancer therapeutics, the past and present actually, a medical oncologist perspective, with more focus on the newer drugs, that the targeted therapy and the immunotherapy. So before going into it, what is cancer actually? So cancer is a group of diseases. So keep it in your mind, it's not a single disease, it's a group of disease and refers to cells that grow out of control and invade other tissues. So it's simple to explain to our patients. Cancer is a group of disease and a single drug cannot treat all cancers. There's nothing like an Atamuli. It is definitely treatment and according to the type of disease we have to treat. The cells becomes cancerous due to the accumulation of defects or mutations in the DNA. So basically, cancer develops as a result of the accumulation of genetic changes to our DNA, and cancer is a genetic disease. So cancer is a genetic disease. That doesn't mean cancer is a hereditary disease. The hereditary familial mutations are only very rare, according to for about only 5 to 10% of cancers. So basically a genetic disease due to defects in the genetic mutations, due to accumulation of genetic mutations in the DNA. Just briefly going before to the causes of cancer, there are non-modifiable risk factors like age. As the age increases, the chances of accumulation of more and more genetic mutations that can lead to cancer. Gender, inherited genetic factors, though rarely 5 to 10% can cause cancer. The skin type. But what I'm focusing more is the modifiable risk factors. So according to the American Cancer Society, 42% of cancers are preventable. And out of which the most commonest cause of cancer is tobacco, smoking. 19% causes of is due to smoking. But the second most common I like to highlight is obesity. So obesity is the second most preventable cause of cancer. And the studies say that by 2030, it's going to overtake even tobacco. Another 5% alcohol, UV radiation 4.7%, physical inactivity 2.9%, and poor diet 1.9%. So think of it. Lifestyle modification alone can prevent approximately 40% of cancer. That's a huge number. So healthy lifestyle, stop smoking, good physical activity can actually prevent a lot of cancer. So always keep in mind, prevention is always better than cure. Now coming to cancer therapeutics, the topics as such. So why should we discuss about cancer therapeutics in such a general meeting? We always think cancer as a rare disease. Is it so? Never. Cancer is not a rare disease now. And It's the second leading cause of death, second only to cardiac disease. So it's quite a common disease and quite a huge cause of death. And another astonishing data I could see while preparing for this slide is that 1 in 6 people die of cancer in the world. So that is quite a huge number. So the main aim of cancer therapeutics is to decrease the cancer related mortality. So luckily, oncology is such a segment in the medicine in which the maximum research is going on. When I search literature, about 40% of medical research is in the field of oncology for preventing cancer and for treatment of cancer, so that this cancer related mortality will be reduced. So this is cancer through the years, cancer treatment through the years. As Dr. Anil sir has rightly mentioned, it started in 3000 BC with the crude methods of surgical treatment, surgical removal of tumor, after which most of the patient died. Then came the radiotherapy, which was initiated in 1900. The first chemotherapy that was approved, that was given was not approved, given was in 1940s, nitrogen mustard, which was found useful for the treatment of lymphoma. Then came the targeted therapy. A lot of chemotherapies came. The targeted therapy came. 1996, first targeted therapy, imatinib, was approved in the treatment of chronic myeloid leukemia, and it actually revolutionized the treatment of chronic myeloid leukemia. And now it's the era of immunotherapy, immune checkpoint inhibitors. So I'll be going briefly with this. So whenever cancer therapy comes to our mind, this first thing that runs to our mind is the chemotherapy, cancer chemotherapy. So what is actually chemotherapy? In early 1900s, a famous German chemist, Paul, said about developing drugs to treat infectious diseases. And he coined the term chemotherapy and defined it as the use of chemicals to treat diseases. He actually used chemicals to treat infectious diseases like syphilis, but later on it became synonymous with cancer treatment, and chemotherapy, almost all chemotherapeutic agents were used in the treatment of cancer. So in the initial period, 1960, surgery and radiotherapy dominated the field of cancer therapy. Then came the era of combination chemotherapy. I think adjuvant chemotherapy was approved in 1970s, 8 to 80s. It was initially approved. Adjuvant chemotherapy, the main role was after surgery to prevent further development of disease. To cure the micrometastasis, we have been using adjuvant chemotherapy. Multiple chemotherapeutic agents were combined together so as the side effect profile were reduced. Now it's like combined modality treatment. It's not chemotherapy alone, it's not surgery alone, it's not radiation alone. Basically, cancer treatment is a combined modality treatment by surgical oncologists, by medical oncologists, radiation oncologists, and also the palliative care physician coming to the stream right at the start of treatment, because it is quite important to palliate the symptom. So palliation doesn't mean end of life treatment. Palliation means to support the patient right from the start of diagnosis. So these are the 4 branches of cancer treatment that is coming up. So these are the key advances in the cancer treatment. I've told nitrogen mustard was the first agent used in the treatment of cancer. It was used in lymphomas. It was in 1940, 1943. Then many drugs were allowed. But before that, the first malignancy to be cured with chemotherapy was in 1958. A case of choriocarcinoma was cured with a systemic agent, symbol methotrexate. So this was the first instance in which a cancer was cured without surgery or radiation. Chemotherapy alone was used. Then later, a lot of drugs came, 5-fluorouracil, antifolates, anti-tumor antibiotics. Then came the taxanes. All these were approved. Then was the era of the monoclonal antibody. Then came the tyrosine kinase inhibitor. I discussed earlier that the first targeted therapy that was approved was imatinib, actually, in chronic myeloid leukemia in BCR-ABL positive cases in 1996, imatinib, and it revolutionized the treatment of chronic myeloid leukemia. Then came multiple tyrosine kinase inhibitor came. The first one was EGFR inhibitor, geftinib, and it also revolutionized the stage 4 CA lung. Stage 4 CA lung, the prognosis was abysmal, but with targeted therapy, we could treat CL lung like a chronic disease with only tablets. And then came immunotherapy. I'll be briefly coming to the targeted therapy and immunotherapy in my later slides. So with cancer therapeutics, the cancer diagnostics also improved. Initially, it was like just get an FNAC, diagnose it as cancer, or get a biopsy, diagnose it as cancer. Whatever be the cancer, we'll be giving some chemotherapy because we have only a handful of chemotherapy in our arm, in our armamentarium. But now we have got a lot of treatment. The IHC is our help to guide in the diagnosis of different histologies, and it's basically histology-based treatment. For each histology, we'll be using different chemotherapy and different combination regimes in the treatment. So this has all changed. But after IHC, what is next? Now come to the molecular diagnostic test and genomic profiling. So these are increasingly used to find the targets so that we can easily target those targetable mutations. If you're getting some mutations that can be targeted, we can easily use the targeted therapy, and thereby the side effect profile can be dramatically reduced because we'll be targeting only the cancer cells and the normal cells will be spared, unlike the normal chemotherapy drugs that we are using. Now, briefly mentioned by Dr. Meera, next generation sequencing. So next generation sequencing, or the massively parallel sequencing, represents an effective way to capture a large amount of genomic information about cancer. We can plot all the mutations that can be targeted, and if any of these mutations are present, we can use the targeted therapy against those mutations, and thereby the response rates and the disease can be reduced. So coming to the era of personalized medicine, I'll be taking the lung cancer as an example to explain what is personalized medicine actually. So I've told cancer is not a single entity, it's a group of diseases, but now it's like even a single lung cancer, the non-small cell lung cancer is not a single entity. So non-small cell lung cancer initially we used to treat as a single entity. We used to give chemotherapy in stage 4 disease, nothing other than that. Then came the histology derived. With the immunohistochemistry, we can differentiate between, and also histology based, histopathology based, squamous, adenocarcinoma, adenosquamous, the large cell, and according to the histology, we are using specific chemotherapeutic protocols. But now it's not the end. It's like adenocarcinoma can again be divided, can again be subdivided according to the genetic mutations. So adenocarcinoma is not a single disease. It's a group of diseases with multiple mutations, and the most common being EGFR mutation, which approximately is around 17 to 18% in the whole population. But in the Asian population, it is estimated that the EGFR mutation is around 35 to 40% of our adenocarcinoma. We can very well easily target the EGFR mutation. So is the ALK mutation. There are a whole lot of other mutations as well, like the ROS1, BRAF mutation, the NTRK mutation, which can all be targeted with targeted therapy. So just briefly coming to the drugs, the EGFR positive, we have got multiple drugs in our armamentarium. I'll show how effective this as against the chemotherapeutic arms. By using targeted therapy, how the response rates are increased with very less side effects. So we have got geftinib, erlotinib, afatinib, and osimertinib, all right now available here and frequently being used to our patients. So if you see the response rates, if you just see the response rates, we can see geftinib versus paclitaxel and carboplatin. The response rate is more than twice, 31% for response rates for the chemotherapy, whereas 74% for the geftinib arm. If you see the erlotinib versus chemotherapy, it is 83% versus 36%. So almost twice the response rates with very less side effects. So if we can find a target in malignancy, definitely we have to go ahead with the targeted therapy, and thereby the response rates, the progression-free survival, all are improved with very less side effect profile. Now this is another one, ALK inhibitor. ALK can be given, ALK inhibitors can be given in ALK mutation positive, like the crizotinib, ceritinib, alectinib. A lot of drugs have come into, and all we can see that the response rates are very much improved. 74 versus 45, 72 versus 26. Even the alectinib arm is showing 90% response rate. So most of the patients with target have got very good response rates with very less side effect profile. So this is what the next generation sequencing is going to help us. We have got a whole basket of drugs. We can choose, we can see what mutation is present in the cancer, and we can choose from this basket and give accordingly. Thereby, the patient's side effect profile, the patient's quality of life will be improved with very good response rate and very good survival improvement. So this is what happening with targeted therapy. This is what happening with the improvement in diagnostic technique, the next generation sequencing. We are actually choosing medicine according to a person's mutation, and this is known as the personalized medicine. Whatever mutation is present, we can actually choose from those mutation. We can choose from this basket and give to the patient. Now coming to the next one, immunotherapy. Some important salient features of immunotherapy has already been mentioned in the previous slides. So what is immunotherapy? What is so different about immunotherapy? So immunotherapy targets the body's immune system, not the tumor cells. So that is one important thing. They actually enable the immune system to selectively recognize and attack the cancer cells. And another important thing by immunotherapy is that just like vaccine, they have got long-lasting memory to the immune system so that it can continuously adapt to the cancer over time and provide durable response. So many of my friends, many of my medical oncologist colleagues would agree that the patient has got response, good response initially, they have got sustained response with immunotherapy. Usually that's not seen with chemotherapy, always the resistance come up, but with immunotherapy, when the patient has got a response, they are bound to respond for a longer period. So it is one important, and many a times in stage 4 disease, we can see complete, even complete response with immunotherapy. So how the immune system attacks cancer? So there is the tumor cells. This is a simple diagram. Tumor cells release the tumor antigens. The antigen presenting cells gather the tumor antigen to present to the naive T cell. The naive T cell gets activated, and these activated T cells attack the tumor cells and destroys the tumor cells. So why it's not happening in any cancer patient's body? Why the cancer patient's immune system is not attacking the cancer cells? So I'll be discussing about the T cell activation. The naive T cell to T cell activation requires actually two signals. One signal is the antigen generates to the antigen, that is the antigen generates, that is the dendritic cell, the antigen presenting cell presents the antigen to the T cell, and this antigen generates the signal 1. Next signal is by the co-stimulation of CD28. So these two signals are required for converting the naive T cell to the activated T cell. So this is what happening. This is how the cancer cell escape the immune system. So the T cells actually have got a CTLA4, and this CTLA4 actually binds to the CD80-86, and thereby the CD28 co-stimulation is not happening. So what we have used? We used a anti-CTLA4 antibody, ipilimumab. So ipilimumab attaches to the CTLA4. This anti-CTLA4 attaches to the CTLA4, and the co-stimulation of CD28 happens, and thereby the naive T cells get activated, becomes the activated T cells and can attack the cancer cells. Is there any other mechanism? Yeah, definitely. There is a programmed death receptor 1 in the T cell and the PDL1 ligand, that is the programmed death receptor ligand in the cancer cell, and these two gets attached. The PD1 attaches to the PDL1 and leading to the regulation of immune response and inhibits the tumor cells from attacking, the activated tumor cells from attacking the tumor, and thereby the tumor escapes the immune system. So these are the two mechanisms. One is by the CTLA4 and another is by the PD1 PDL1 combination. So these two mechanisms is by which the cancer cells escape the immune system. So what we are doing, we have already mentioned about ipilimumab, that is the anti-CTLA4, and now we are using the anti-PDL1 like the nivolumab and pembrolizumab, so that the immune system gets activated and attacks the cancer cells. So we have got a whole lot of drugs: nivolumab, pembrolizumab, atezolizumab. Specialty is that nivolumab and pembrolizumab right now is approved in almost all malignancies in the second line. In certain indications in second line, if the MSI high and all, we can actually use pembrolizumab in the second line in almost all cancers. And also in lung, we can use it in the primary. Combination of immunotherapy with cancer chemotherapy. The chemotherapy is being tried, and here we can see that pembrolizumab plus chemotherapy in the first line is showing a survival benefit in almost all patients. So right now we are adding pembrolizumab plus chemotherapy right now in CA lung patient without any targetable mutation. This is the first line option that can be used for best response rates. So just show, I will go into one of my patients to show the efficacy of immunotherapy. 60-year-old male, it's a non-diabetic chronic smoker, 30 pack years, more than 30 pack years, presented in December 2018 with a 1-month history of cough and occasional hemoptysis. Chest X-ray showed a right upper lobe apical lung lesion. PET scan was done in Jan 2019, a right lung lesion with mediastinal invasion, FDG with mediastinal lymph nodes, and a right supraclavicular lymph node, FDG with metastatic cervical lymph node. Lung biopsy showed adenocarcinoma, which was TTF1 positive. TTF1 positive means it's a lung primary adenocarcinoma, non-small cell lung cancer. And FNAC from the cervical lymph node was proven to be metastatic adenocarcinoma. It was EGFR mutation negative, ALK negative by IHC, and PDL1. PDL1 is the ligand which is expressed over the cancer cells, and PDL1 more than 70% positive by DACO method. So this was the initial PET scan showing the lung lesion, the mediastinal lymph nodes, the cervical lymph node. He was started on pembrolizumab from Jan 2019. So this was the initial PET scan, and after 4 cycles there was a partial response. The FDG ability decreased, the size of the lesion decreased, and the patient was continued on pembrolizumab, was continued, there was no toxicity. After 16 dose of pembrolizumab, there was a partial response on CT scan dated 16 February 2019. Post 25 cycles, PET CT showed mild increased FDG uptake. The patient was clinically asymptomatic. We were doubting pseudo progression. The patient was continued on pembrolizumab, and the latest CT that was done in December 2020, showing almost very good response to the pembrolizumab, and still he's continuing on pembrolizumab. He has taken around 31-32 injections till now. So what we have done is, which we cannot describe actually in chemotherapy, because almost 2 years on a single agent patient is going on. Patient is a businessman. He is going to his shop with no more large comorbidity. He is going on his with work. No usual side effects of chemotherapy. He's doing all his work with good quality of life. So we have changed a highly mortal disease with high mortality, CA lung stage 4, into a chronic disease actually. So this is what we have to do. We used to tell that you can't die of Alzheimer's if you have got cancer. So what we are doing with the modern treatment, we are curing many malignancies, many cancers, and at least we are changing cancer to a chronic disease. Thank you.
Thank you, Mithun, for taking us through the evolution of systemic therapy. Now, from my point of view, with the introduction of a drug called imatinib in chronic myeloid leukemia, the targeted therapy era has started. And I remember before the advent of this imatinib, most of the patients with CML were dying. And with the imatinib and several other targeted drugs, I think I don't see any patients dying. Almost 96-98% cure is there. And I tell you that these drugs are not very, very expensive if in Indian scenario. Say for an CML, chronic myeloid leukemia, The imatinib costs approximately 5,000 rupees a month. Even the original, the innovative brand cost about less than 10,000.
Now the dasatinib is costing 6,000, 7,000.
Yeah. Then, of course, the immunotherapy at present is very expensive, but probably after a few years, once the patent is over, then probably we can use these drugs more extensively. I think there will be a lot of questions, clarifications. I would like to start with Dr. Meera. A simple question. In your practice of patients with multiple myeloma, what percentage of patients undergo transplant?
I'm from a very transplant-heavy service here. So in our population, every patient who are otherwise medically fit are transplanted. I would say like 80% or so of our patients, and we do this outpatient too. Like 80% of our transplants are outpatient. 80% of patients are transplanted. We in fact even have, as I said, 75-year-old, 80-year-old patients who have really done well with transplant approaches.
Right. We in our institute also we see quite a good number of myeloma patients, and in Amala we are going to start a transplant program in by June. That's why I asked questions. So other questions, clarifications. I see Dr. Sriraj, Dr. Sunu here. They can have their comments. Others can have doubts, clarifications.
Meera, that was a wonderful talk. So what's your experience about the CAR T therapy in myeloma? Like how you select patients for the CAR T therapy, and what is your experience on the remission?
Thanks, Sriraj. That's a good question. So CAR T therapy.
I know your center is well versed in CAR T, no? Yeah.
Yeah, we have our own CAR for lymphoma, and we have several clinical trials for myeloma CAR. CAR T at this time, most of the CAR T therapy is offered in the relapse setting in patients who are penta-refractory. They are refractory to lenalidomide, pomalidomide, daratumumab, bortezomib, and carfilzomib. At this time, we do see a very good overall response rate, especially with the J&J CAR. But the duration of response is still not, we don't have a long follow-up. So the duration of response is not very clear, but very good overall response, very good MRD negative CRs. We also have currently a couple of clinical trials, the KarMMa-4 and the CARTITUDE-4. So these are enrolling patients post-transplant who, that is the KarMMa-4, who have relapsed post-transplant. Relapse after transplant is considered very high risk, so those patients are enrolled. And then the CARTITUDE-4 is enrolling newly diagnosed patients who are high risk by RSS-IS, stage 3 diseases. So the future is bright. That's all I can say at this point. But lymphoma CAR, as we know, is like extremely good outcome and very well tolerated. And hopefully it'll be the same, and it'll likely be approved for myeloma in April of this year. The BCMA CAR will be approved for myeloma this year.
Hi, Dr. Meera. My name is Dr. Sunu. I'm working in Namla with Dr. Anil. I just want to ask something. I don't know. I think you haven't practiced in India as an oncologist, isn't it? But from your literature, but from your knowledge, do you think that there is a higher incidence of myeloma in India and especially in Kerala? Because clinically, in practice, when we see, as compared to practices in other places like Delhi or in even the Western countries, this is my personal feeling. I feel that there's a very much higher incidence of myeloma in Kerala for some reason. Are you aware of something like that in the literature or something?
Thanks, Dr. Sunu. I'm actually not aware of the prevalence of the cancer in India. As you said, I haven't practiced in India at all. So that'll be an interesting question. That'll be something that we could look at possibly, you know. In fact, I mean, in general, what I understand is the cancer incidence in India is pretty high compared to, you know, what you would expect. Yeah. So.
And one more thing related to myeloma with renal failure, in those patients with very high creatinine and all, apart from the routine dialysis, do you do anything else to immediately bring down the load, like plasmapheresis, or in your routine practice, like high cutoff dialysis or something like that?
That's a good question. So we really don't do any plasmapheresis as such. The only indication for plasmapheresis is when they have high hyperviscosity in the setting of IgM myeloma, not even IgG. If we have hyperviscosity, we treat them. That's pretty much. So our approach to patients who present with renal failure is start them on treatment. And of course, nephrology, if they think there's an indication for dialysis, we proceed with that. But starting them on treatment is the most important step. Because in their publication by Dr. Barlogi and colleagues in leukemia, it's probably one of the first in 2015, they published how if the patient can have a reverse, if we could reverse the patient's renal failure, the survival is pretty comparable with patients who does not have renal failure. So our standard approach is, so in this practice here in Milwaukee, they use like Cyborg-D with DARA, or you know, we have a clinical trial with adding isatuximab to Cyborg-D. But in Arkansas, the standard is VDT-PACE without the cisplatin, obviously.
Meera, if there is a high light chain burden in renal failure, in acute renal failure with high light chain burden, is there a role for plasmapheresis or high cut dialysis? Now, there are a few articles mentioning that, no?
Yeah, there was a couple of trials, I think from Europe, but the results are not very consistent. But in our own clinical practice, starting treatment early is the most important step. So I would, if there was a patient, you know, you're not sure about where to approach, steroids, which should be the first thing we should do. And obviously Velcade is pretty safe, you know. And thalidomide is actually safe. Lenalidomide can be a bit tricky. And I'm not sure about the expense of, you know, such a procedure, plasmapheresis in India. If it's cost, it's not cost effective, at least to according to our practice. So why subject a patient through an expensive procedure, you know?
We have tried for few patients here in our in Amala in acute kidney injury. We have mixed results. That's why we asked the question.
Yeah. So there was actually a recent paper from University here in the Medical College of Wisconsin is one of the biggest blood centers in the world. So the literature is mixed, Sriraj. So and you know, if I have a patient, I would definitely start treatment. The only indication for plasmapheresis would be IgM myeloma. With hyperviscosity syndrome, because you know IgM, as we know, is more intravascular. You know, unlike other isotypes which are not as heavy as IgM. Yeah.
Any other questions from audience?
Dr. Meera, Dr. Mithun here.
Yeah, hi Mithun, how are you?
Yeah, I'm fine. Yeah, any means with newer immunotherapy and all coming in the treatment of myeloma, do you think in certain patients, at least in certain patients, we can avoid autologous stem cell transplantation?
So transplant, Mithun, transplant is to stay in myeloma, because we had the recent IFM data that was published at the ASH meeting in December, where they compared delayed transplant. You know, they had the IFM study VRD with our transplant approach. So the outcome, the overall survival was the same, but transplant induces deep remission. The key to myeloma cure is deep remission. So delayed transplant, as per their you know presentation at ASH, was equivalent to early transplant. But transplant is a procedure. One, is very cost effective. Melphalan is probably one of the cheapest drugs we have for myeloma. You know, it gives you that upfront chance of long-term remission and long-term better outcome. So so transplant is the way to go. In I mean, I know there is an increasing move, especially from since that IFM data came out, that there is a move towards delaying transplant, but that isn't a very cost-effective method. And yeah. Immunotherapy, your next question was immunotherapy. So there was the pembrolizumab study in multiple myeloma that was actually conducted at our center here at Medical College of Wisconsin by Dr. D'Souza. So what they did was post-transplant, they had patients with pembrolizumab, they randomized, I mean, it was a phase 2 study. They had patients with pembrolizumab along with the lenalidomide, but that was associated with very, the results were not impressive. It was a negative study. But then we have newer immunotherapy like TIGIT, antibodies instead of PD-L1. So that is apparently, upcoming and, but nothing active, as of this point. Not PD-L1 is probably not the way to go in myeloma.
Is the center doing a tandem transplant right now?
So I'm actually a little biased because I've been in the University of Arkansas for 6 years. So my knowledge of myeloma is a bit, lean towards what they do there. So tandem transplant is what Arkansas offers, and for most of the patients. And the results are like you've seen the results, like the slide that I showed, the long-term outcome is pretty good in tandem transplant. But again, the EMN data that was recently published, I think in Lancet, showed that there is a role for tandem transplant in high-risk patients like the 17p deleted. But of course, the randomized study, the STAMINA trial, that was again done at the Medical College of Wisconsin. Dr. Hari presented it at the last ASCO meeting. It was negative. But the intent to treat population, there was some suggestion that tandem transplant might be beneficial in high-risk patients. The key is, if post first transplant, if we were not to achieve MRD negative CR, that's is a challenging situation. That is when we have to decide what do we proceed. So in that condition, the options are either a tandem transplant, or CAR T therapy, or immune-based consolidation with DARA or DARA-based or something like that. So that is a population of patients that is still an unmet need. Like if they don't achieve MRD negative CR post transplant one.
Any other questions from other participants?
Sir, I am Dr. Santosh Babu from Thrissur IMA. Can I ask a question?
Yes.
I have two questions now, directly related. Any scholars can ask. What is the status of cancer registry in Kerala? That is my question number one. Can you suggest at least first best insurance for cancer care in India?
Dr. Sunu, you want to answer that question?
Yeah.
Cancer registry.
Yes, cancer registry I can answer. I didn't hear the second question. The second question is about what?
It's about insurance.
First three best insurance for cancer care in India.
Okay, that I might not be the best person, but the registries I can tell you. The registries, the ICMR, Indian Council for Medical Research, has come out with, it's there for the last many years, with two kind of registries. One is the hospital-based cancer registry and one is the population-based cancer registry. And they regularly come out with reports and updates about the number of cancers. They take the data from different cities, almost covering all corners of the country. It is a sample data, and they come up with the population-based and as well as the hospital-based. In Kerala, the population-based cancer registries, as much as I know, is operating from RCC Trivandrum as well as from NCC Thalassery, Malabar Cancer Center Thalassery. Hospital-based cancer centers, we have quite a few hospital-based cancer centers across the state. In Thrissur, we have a hospital-based cancer center currently now in Amala as well as in Medical College Thrissur. I'm not sure whether Jubilee has got, Mithun can correct me if Jubilee has got that.
Yeah, we have started.
Okay.
Hospital-based.
So we are going to, from Amala, we are going to come out with our first cancer registry report, hopefully by this year. Hopefully the 2018 report will be coming out with this year. And apart from that, we have also started one more comprehensive cancer registry for our institution, specifically in collaboration with a few other institutions like JIPMER Pondicherry and All India Institute Rishikesh. This will be a much more comprehensive cancer registry covering more data than the ICMR cancer registry, which will be.
Sunu, you have muted.
Sorry, you didn't hear anything? Okay, sorry.
Yeah. Okay.
But only last part.
Okay, so we are coming up with one more elaborate comprehensive cancer registry involving in collaboration with the institutes like JIPMER Pondicherry and All India Institute Rishikesh and CMC. So we will be coming out with a more detailed registry data than what's required from ICMR. So currently from the government sector, we have the ICMR hospital-based cancer registry and the population-based cancer registry. Independently, we are also doing another cancer registry from our institute specifically. Insurance question, I am not sure exactly. There are so many companies coming up with private insurances. I have personally myself taken one for my family, but I don't know. I haven't compared anything between. I think somebody will be the better.
My opinion in the insurance sector is, in India, the private insurance is a little bit tricky. It is difficult because of the premium. People are not, not willing to pay. Probably the better way is to give more coverage to the ESI by ESI methods, the government things, or schemes like RSBY or something, and cover those wide range of people. And the middle or upper middle class definitely can take private insurances. Like we have a lot of insurances like LIC. That is that is my suggestion. Lower middle class or lower class definitely should be covered by government schemes. They will not pay a premium by private insurances. That's what the history shows. Any other questions?
I am Dr. Parameswaran from Palakkad. May I speak to Dr. Meera Mohan?
Meera?
Yeah, sure. Yeah.
My one of my relatives underwent a autologous bone marrow transplantation for multiple myeloma, and she received a VRD regime 4 cycles before autologous bone marrow transplantation. And she, following the autologous transplantation, she was put on bortezomib and lenalidomide again. But she developed allergy to bortezomib. She developed peripheral neuropathy for bortezomib and skin rashes and allergy for lenalidomide. So she was put on carbidopa and pomalidomide.
Okay.
But now the investigation showed that she was diagnosed with IgA lambda myeloma. But now the investigation revealed that she has high levels of light chains lambda. Which was normal even after the autologous bone marrow transplantation and even after the consolidation. But after 6 months of transplantation, her lambda values are 46.
Okay.
Which was normal 11 initially. He is also having a 414 deletion in fish.
Okay.
So, what is the progress of 4x14 in multiple myeloma?
So that's a bit tricky, you know. The GP data that, you know, actually, if you ask me, GP is the best risk stratification tool we have, but then it's expensive. It's like $1,000 for one testing there, even here in the US. So per the data that we have from Arkansas, 414 is a heterogeneous group. Not all 414 are high risk. At least 50% of the 414 could behave like high risk. But the fact that your family member has relapsed early after a transplant is a very high risk situation there, because relapse is even 1 year up to 18 months after first transplant is a bit tricky. So perhaps an alternative immune approach of treatment might be better in somebody who relapses early.
So this lambda, the high value of lambda means that it is a clinical relapse.
Oh yeah. Oh yeah. I mean, it all depends, but it all depends on if she's had a PET CT, because if you have relapse with a PET positive, like PET focal lesion or MRI focal lesion, that is extra high. Like that determines, and we'll have to look at the bone marrow metaphase cytogenetics. So there are several things that we have to look up and see how things are. Not just, I mean, clearly it sounds like relapse here, but the bigger picture is full staging. So we'll have to see how the PET and MRI MRI and bone marrow studies and all that. Look, she could have gained 1Q amplification. There are several things that help us determine a prognosis. But early relapse after transplant is an unmet need, and it is of concern.
Okay. Thank you, Dr. Meera.
Thank you.
Thank you so much.
Good evening. Hello, Dr. Meera. I am Dr. Anil, physician from Thrissur. Can I ask you a question?
Sure.
The thing is that how many percentage of your patients with multiple myeloma you diagnose amyloidosis, and how do you diagnose it? The traditional teaching is that we will be having a nephrotic range proteinuria, hepatosplenomegaly, and rectal biopsy showing green birefringence and beta plated appearance and all. How do you diagnose, and how many percentage of patients you diagnose amyloidosis, and how will you treat it?
So it's a bit tricky, you know. So overt amyloidosis, as you said, presents with proteinuria. But then, so in our practice, so any patient that comes in, especially if they have lambda light chain, we get an NT-proBNP at baseline. So high NT-proBNP will be out in the outlook for amyloidosis. Like, and it mostly, we have to be looking out for these symptoms. Like echocardiogram is always done before transplant as a transplant clinician. So we have to look out for any changes of amyloidosis in a plain, like a regular echo. And I said about peripheral neuropathy, peripheral neuropathy or severe orthostatic hypotension. So it's very subtle, these symptoms. So any patient who's diagnosed with myeloma, if they have symptoms that you cannot explain, will have to be on the lookout for amyloidosis. So in amyloidosis, the management depends upon the percentage of the plasma cell clone. If it is, if we at least have like 10% or so, we try to do a MEL transplant based approach. But again, as we know, transplant and amyloidosis is pretty tricky. So in our practice, at least I'm actually relatively new in Medical College of Wisconsin. From at least the practice in Arkansas is if a patient has amyloidosis, we try to do the stem cell collection, like a G-based stem cell collection inpatient, because they are very, very prone to arrhythmias, and they can die on you, like they can have serious cardiac problems and can die even before we start treatment. So the inpatient collection, we kind of liberally use plexiform, and everything is pretty much inpatient for these patients. In transplant also is done particularly inpatient, Yeah, and these patients, you might not have to do a full MEL 200 transplant. We could do a MEL 140 or even fractionated melphalan transplant. But we've had a very good outcome even in cardiac patients who could safely undergo transplantation for amyloidosis. But again, the diagnosis is very tricky. We'll have to really look for symptoms, and anything that cannot be explained by myeloma, we'll have to make sure it's not amyloidosis. We've even gone far to the point that if a patient has peripheral neuropathy and if the patient is African American, we get a nerve biopsy, make sure that, because African American patients can have other type of amyloidosis, like ATTR and all that. So we maintain a very, very high level of suspicion in these patients. There's no it's not clear, it's not straightforward, the bottom line.
Thank you.
Good evening, Dr. Meera and Mithun. Excellent presentations from your side. See, I'm so proud of you, Mithun. Meera, hi. Arun told me that you are his classmate. Nice to meet you. See, on World Cancer Day, with all respect to the medical oncologists here, my concern is regarding the skyrocketing prices of the drugs. Having seen a few of my relatives having malignancy in the very recent past, the cost, I don't know what it is outside, but in India, even for a upper middle class or a high class family, it is difficult. The therapy, the regimes are beyond their affordability. And now here I would like to request your society, the AMPOK association, if something can be done from your side, a memorandum or something which can be given to the government so that the treatment can be subsidized in some way, or is there anything which can be done to the favor of the society. That is my concern here, which I would like to raise on World Cancer Day.
I actually clarified those things because when you compare the innovative brand and Indian brand, there is a tremendous difference. The innovative brand, they will not be able to reduce price beyond a particular limit because of some technical reasons. What they do is they give free medications, free medicines, and the Indian brands, definitely there is a good competition, and the prices reduced in the recent years. And I think in chemotherapy, the prices is definitely not overpriced. Yes, the newer drugs like immunotherapy, because we don't have Indian, the treatment is definitely very, very costly, expensive. Two things we can do is, one is, as Dr. Santosh was telling, the people should, we should make sure that at least 80%, 90% of people should be covered by some way of insurance. That is one way out. That is one thing what we can do. And second thing is, by just because of competition, they are reducing. Still, we as in our institute, what we do is we ask for a tender, the drugs for the chemotherapy drug, and we take the cheapest but standard companies. That is what we can do. In the government level, I do not know. Ideally they should do is to reduce the MRP of these drugs, but it has some technical problems, like the tax is calculated according to the MRP value. That is why I think government is reluctant to reduce that.
Nivin sir, one thing I should point that chemotherapeutic agents right now, I think it's the cheapest in India. I don't think any more cheap you can get. And another problem of decreasing the MRP, there is price control by the government, and some essential drugs we are not getting right now, like ifosfamide. It's too cheap, so that many companies have stopped production. So right now we are not able to get those drugs because of the price control. Ifosfamide, I think right now is out of stock in Kerala,
Yes.
at least South India.
Yeah.
So that is one other problem of decreasing the price. But right now, the price wise, I think in India it's the cheapest.
Yeah, Mithun is right. Actually, there was a recent publication by Srijesh. Srijesh is one of our, he actually graduated from Thrissur Medical College as a pathologist. So he had published in JOP how the prices in India compared to the US. It's terrible in the US. Melphalan here is $10,000. I don't know how much is Melphalan in India. So it's terrible. CAR-T therapy we spoke of is $500,000. So yeah, I think India has better prices. It's just an access issue mostly.
In India, in our place, if you take the myeloma treatment per month, it may be costing 10,000, less than that. When you combine len and bortezomib.
Yeah.
So it's
cheap. Here it's 300,000 for a year. Yeah. It's 300,000 for 1 year of therapy, BRD.
Okay. Any other questions, clarifications? Okay. If none, I think we can wind up. Again, thank you very much, Dr. Meera and Dr. Mithun, for your wonderful talk, and I thank all the participants for active participation. Dr. Joy, thank you very much. I think we can wind up the scientific session.
Okay. Thank you,
Thank
Dr.
you. It was a
Anil,
pleasure. Thanks.
Thank you, Dr. Anil, Dr. Meera, and Dr. Mithun. And now I invite Dr. Sharmila for the vote of thanks.
Thank you, Dr. Joy. I would like to thank Dr. Joy Manjila, IMA President, Dr. Pavan Madhusudan, Secretary, Dr. Leelama Abraham, President, Chairperson, IMA CGP, and Dr. Arun Krishna for their support in conducting this CME. And I would like to thank Dr. V P Gangadharan sir for inaugurating this CME, which we conducted in regarding the observance of the World Cancer Day 2021, and in spite of his busy schedule. Now I have to ask for forgiveness from today's moderator. I'm afraid I inadvertently omitted to mention the resume of today's moderator, Dr. Anil Thazhath. Sorry, sir. Now I have to do it. I'll be doing it. Dr. Anil Thazhath completed his MBBS from Thrissur Medical College in 1988, and he did his MD in Radiation Oncology from CMC Vellore, and DM in Medical Oncology from Cancer Institute, Adayar, Chennai. Sir has many publications and research reports, papers to his name, and sir is the professor and HOD of the Department of Medical Oncology and Haematology, Amala Institute of Medical Sciences, Thrissur, Kerala, from 1998 till date. Thank you, Dr. Anil, for being a great moderator. And as you rightly mentioned, this had been a mixed group. And now the webinar CMEs have enabled us to get faculties from the Medical College of Wisconsin. We highly appreciate the talk on multiple myeloma by Dr. Meera Mohan, and sharing with us a few cases of her patients. And it was a pleasure listening to Dr. Mithun Chacko John as he took us through the evolution of cancer therapeutics. I would like to thank AMPOK and the members of IMA who are here to listen to the program by CGP. We'll be conducting another program by the CGP next month, so do join us then.